Hi, everyone. Welcome to the Hot Topics podcast of the Neurocritical Care Society. My name is Alex Reynolds, and I'm a neurointensivist at Mount Sinai Health System in New York City. And I'm really excited today to present to you a group of people who are going to be discussing minimally invasive ICH evacuation. So we're lucky enough to have the ENRICH group from Emory, who will be speaking about their latest study. And we'll also have two people commenting on the results of the study. So we'll start off by introducing Dr. Gustavo Pradilla. He is an associate professor of neurosurgery at Emory and chief of neurosurgery at Grady Memorial. We also have Jonathan Ratcliff, who is associate professor of emergency medicine at Emory and a neurointensivist. And we have Alex Hall, assistant professor of emergency medicine and director of clinical trials, also from Emory. So the three of them are going to be presenting the results of the ENRICH trial. And then we'll have Dr. Christopher Kellner, who is assistant professor of neurosurgery and director of the IntraCerebral Hemorrhage program at Mount Sinai Health System, to comment on the neurosurgical perspective on this trial. And we'll have Dr. Kara Melmed, who is an assistant professor of neurology and neurosurgery at NYU Langone, to provide the neurointensivist perspective on how this trial might be changing the scape of medical and surgical care for ICH patients. So with that, I want to invite the Emory team to speak to us about their trial, or early minimally invasive removal of ICH, or ENRICH.
Okay, we haven't had a chance to discuss how we would proceed with that. So I think the first thing to talk about before we talk about ENRICH is why we wanted to do ENRICH. So ENRICH was first conceived approximately 7 years ago is when we started discussing the trial design and the rationale for the trial. And that came about because we had a group of neurosurgeons primarily who were starting to use this minimal access ports for different surgeries, not just for intracerebral hemorrhage. A lot of tumor work was being done in that. And ICH became one of the uses of that technology that seemed to make sense, and a few people started to do it and saw some promising results. So there was a prospective registry that was put together by a neurosurgeon named Mohammed Labib, who is now at the University of Maryland. And that had 10 centers that contributed some patients to that. It was a very small study, it was 50 patients. But it was the first organized attempt at seeing if this was something that made sense that we should pursue further. And we had some promising results there with regards to the amount of hemorrhage that was evacuated and the safety of the technique. And we saw some very preliminary reports on improvements in Glasgow Coma Scale pre and post-op. So that was the initial interest in it. Was this MySpace prospective registry. And then following that, we decided to put it to the test in a more rigorous way. Once MySpace was published, a couple of single institution centers were published. One was the Cleveland Clinic experience that Marta Bain presented. It was a small series, but it showed the same type of results with good clot evacuation rates, over 95% in Mark's series, that were also interesting. And one of the things that we liked a lot about Mark's and the Cleveland Clinic team series was that they saw a lot of positive spot signs in their initial experience, and they were able to get hemostasis comfortably and definitively in all the cases they saw spot signs in, which was about 65% or so. So that was a nice thing. There's another group from St. Louis University that was led by Juro and Copens, and they also had a small series that was a single institution series. So all of that was put together as part of the initial experience for ENRICH. So when we decided to set up ENRICH, Jonathan and I recruited our research team, and Alex Hall was the architect of putting all of the trial logistics together. The trial was funded by the manufacturer of the device, that's NICO Corporation. They make the BrainPath device, which is the port, and they make the evacuation tool, and that's called the Myriad device. So they decided to fund the study, and then we reach out to our colleagues from neuroradiology, from a health economics group to design the quality outcome measures for that side. And we recruited a stroke neurologist, Mike Frankel, who's the head of our neurology group at Grady Memorial Hospital. David Wright, who's our chair of emergency medicine and leads the neuroscience emergency group here. And then we reached out to the best team we could find for Bayesian statistics. That was the Berry Consulting Group, and then we put ourselves in their hands. And Alex, if you want to talk about the initial phases of the design and how those simulations were put together.
Yeah, so basically, we all sit around in a room, talk about what the current existing knowledge and literature is, talk about what we expect performance-wise in a clinical trial through mortality and functional benefit, and sort of what sort of is seen in general medical management. And then the statisticians do thousands of simulations of trials and different possibilities to identify what's likely the most successful way of doing that, whether that's looking at location, be it in basal ganglia versus lobar versus something else, timing. So all these go into different simulations that are run ahead of time. And then we sort of whittle down the inclusion exclusion criteria to try to figure out what's feasible across the possibilities that we can achieve based on our simulations. So that's what led to the enriched population and using an adaptive design where the location could be enriched at multiple interim time points, depending on what the data showed to the DSMB. So that was our general premise starting. And once we selected and finalized the design, then it's kind of out of our hands and runs. Yeah.
One of the critical things about putting this in context of time is that when we started designing the trial, MISTY 2 was just published and MISTY 3 was ongoing. And, collectively, I think in neurocritical care, neurology, and neurosurgery, we all expected MISTY 3 to be positive based on how promising MISTY 2 looked. And it was a very strong team with a lot of very seasoned investigators. So that was something we had in the back of our minds. We didn't know what that was going to look like, but we had an expectation that was going to be positive. And we were rooting for it because the only other trials that we had to look at were the stitch trials, or conventional craniotomy trials, and those were negative. Both stitch 1 and stitch 2 were negative studies. But we incorporated the data that we had at the time. So stitch 1, stitch 2, a very small endoscopic trial that was done in Austria several years ago. We used also all the MISTY data that was available at the time, and we incorporated that into our simulations and into the design of the trial. When we started, there were a few very small experiences on endoscopic ICH evacuation. not to the extent that it is today, and what the Sinai group and Chris has done to bring that technology to the forefront. It was 7 years ago, it was just starting to build that experience. But there was a big experience in using endoscopic techniques for intraventricular hemorrhage evacuation. So that was part of what we were also considering, was technology-wise, what was it 7 years ago? What was at the forefront of technology? That was one big part that we wanted to incorporate into ENRICH, was the best possible technology we can bring to the procedure. And that included several fronts. One was imaging. We wanted to make sure that we had the right preoperative imaging assessment to determine eligible patients, to determine adequate surgical trajectories. We wanted to have the best tools for access that were the least disruptive possible. We wanted to have the best visualization in surgery, what was the best optics that we could get at the time, and the best tools for efficient clot evacuation, get the clots out in a quick and proficient way, and also the best hemostasis. Some of the concerns with doing cases that have positive spot signs and doing ultra early surgery, of course, primarily relate to your ability to get good hemostasis. So that was one of the key factors we considered when we put the approach together. And while in the early phases, we did a lot of tractography to validate the trajectories that we were going to pick. As we did more and more cases, the need to use tractography decreased for ICH primarily in two of the three most common locations. So for anterior basal ganglia hemorrhages and for the majority of lobar hemorrhages that reach the surface, we had a pretty good idea what the trajectories were going to be like without having to use tractography. For thalamic hemorrhages, those were the ones that we were relying most heavily on tractography. And those were the ones that at the end of the day, we decided to exclude. One, for that reason, but second, because looking at my space and other studies, the number of patients that were able to achieve a comparable neurological recovery was the same, but the timeline was much more extended. We would see good recoveries in MRS at 6 months in basal ganglia and lobar hemorrhages. Thalamic hemorrhages, probably because of the extension into the midbrain, took 9 to 12 months or sometimes longer to get to the same level. And since we had a limited amount of follow-up based on the design at 6 months, we didn't think we were going to get to see the full extent of the possible recovery for the thalamic. So those thalamics were excluded. So that's also part of the context as to why we selected that type of technology and what the inclusion and exclusion criteria were based on. Jonathan, do you want to speak to the full inclusion criteria that we selected? You're muted.
Yeah, sure. Some of the most important ones that you spoke about was that exclusion of the thalamic hemorrhages and the decision to focus on the lobar and the anterior basal ganglia. Obviously, the volume of the stroke, we wanted to keep it in a tight range of that 30 to 80 cc's, because we've seen clinically and from the data that we have that if you're less than 30 cc's, that the risk of surgery might not actually be beneficial. And over 80 cc's, there's often significant structural damage at the time of original ictus, or at least at the time that the stroke is that sized. We also wanted to get patients that were actually having some degree of significant neurologic impairment. And so the simplest tool that we could use for that was the Glasgow Coma Scale. So we limited that to an upper limit of 14. We wanted to have them be somewhat impaired, as we know that some of these lobar hemorrhages patients can be pretty awake, depending on the location of the hemorrhage, but wanted to have some obvious impairment, but also have a extent of the impairment not be so significant that they weren't patients that people wouldn't want to ultimately operate on. So we cut that at 5 for total GCS score. And the same is true of using the NIH stroke scale. So they had to have an NIH stroke scale of greater than 5. And then with some degree of functional baseline. So we limited the MRS at 1 or better for a baseline MRS. One of the things that we had the most discussion about was what do we define as early surgery? And when we first were planning this study out, and our partner Mike Frankel was the greatest advocate for trying to push the time as early as absolutely possible. And so he was the big advocate for that. And so we ended up making a cut point at 24 hours. And that was really driven by what is practical to some extent in our current world. And also, being able to activate an operating room, identify patient, enroll a patient, et cetera. However, at the time, the only data that we had was from Stitch and from Misty, which were obviously allowing much later enrollments. And from a technical standpoint, Gustavo and Chris could probably speak to this better than me, but there is a practical component that people were concerned about related to time. Gustavo, do you want to talk about that real quick?
Sure. Yeah. When we talked about getting imaging that we could use for intraoperative navigation, and then to get the patient into the operating room, it really required a culture change because most centers did not consider an intracerebral hemorrhage procedure as an emergency. Maybe an urgent case, and those definitions they vary from hospital to hospital, but for our site, an urgent case is within 6 hours of posting the case. But we wanted to have this as the most rapid emergency response case. So it would be equal to an epidural hematoma or something like that. So it required a culture change, and we were able to achieve that in our center, but we saw a lot of pushback in other places. So when we did our site selection, we had these conversations very early on, and we asked our investigators at every site to meet with their OR directors and OR managers and go to the OR committee and change the priority level allowed for an intracerebral hemorrhage so that it would be done as quickly as possible. That was a significant culture change. It's a little bit different to how the workflow happens for Chris and the Sinai team, because having control of the angio suite really allows them to go whenever they want. But when you're sharing the operating room with all the other hospital surgical specialties, you have a lot less control, and you need to have this a priori agreement that you will go and you will bump whatever elective surgery is supposed to happen to get these patients into the operating room.
Yeah, so the other issue that we addressed was uncorrectable coagulopathy. If you had a coagulopathy that could be corrected, then we didn't want to enroll you. We knew at this time, we had DOACs, that they were on the market when we planned the study, and idarosizumab had just become available. And Dexnet alpha was still actually in clinical trials and hadn't yet been approved. So we just said that they couldn't be enrolled if we couldn't correct the coagulopathy, regardless of the etiology of that coagulopathy. And then we also excluded patients with profound IVH or significant IVH, and we defined that at the 50th percentile just because we had to provide a metric for cut point. So if greater than 50% of a ventricle was occluded, then we excluded those patients. And that's just related to poorer outcome and more difficulty managing the patient. So that really rounds out, I think, the major inclusion and exclusion criteria that Alex or Gustavo, did I forget any?
No, I think that's the key in there. And we had one of the key differentiators was time, because we wanted 4 hours, but we encouraged all of our investigators to enroll within 8 hours of last known normal. And what for us in practical terms, it meant that you were able to cross the door to the operating room within 8 hours of last known normal, and with a maximum of 24 hours.
Yeah, and that's what we asked people to target that. People did pretty well with that, honestly. pretty amazingly throughout the trial. And I'm sorry for stepping on you, Gustavo, but the randomization to surgery throughout the trial was less than 2 hours, and most of the time it was about an hour and a half, which is we were pretty happy with that, given that many of these places had to deal with the complexities that Gustavo was just describing in terms of their activating an operating room on an emergent case and changing the culture. But the investigators at each of the 37 sites were amazing at producing that effect.
So how Alex mentioned, the study was designed with adaptation in mind. Like all these adaptive trials, we had a sample size that could fluctuate between 150 and 300 patients. And we were doing block randomization based on 2 factors. The first one was a GCS, and we used greater or less than 9. And the second one was the location. So anterior basal ganglia or lobar were the 2 locations. And Alex, you want to talk about our interim analysis plan?
Yeah, so at 150 patients and every 25 subsequent patients, there was an interim analysis of the primary endpoint, the Bayesian analysis of the utility-weighted MRS endpoint that was presented to the DSMB. And if it met a certain threshold for efficacy or futility, which in that case, futility would be stopping and enriching the other to 1 location only, the DSMB would make a recommendation based on an unblinded review of the analysis. In addition, they of course looked at safety across both groups and performance and several other metrics as sort of standard with any DSMB. And so at 175 patients, that's when we enriched to the lobar location only, which was pre-planned possibility at any 25 increment of patients. And so they had to have at least their 90-day outcome complete to be included in the interim analyses. And we had to have at least 60 patients with full outcomes at 180 days to be able to make any decision rules happen. So that's what happened. And the remaining of the patients we enrolled in just the lobar location. So at the end of the day, or at the end of the trial, we would have 180 days on everybody, and to claim superiority had to be greater than 0.975 of the posterior probability. So that was the target. The interim analysis for efficacy was much higher, as 0.99, greater than 0.99. So that was our model we were working with throughout the entire trial. We audio recorded all the MRS interviews at 30, 90, and 180 days. And then we had a central adjudicator, a neuropsychologist, independently review the audio file and listen to that, and then provide a unblinded adjudication of the MRS based on the interview by the site. And so we had some background things that happened. They didn't get to see what the site entered until the neuropsychologist entered it. And if there was a mismatch, then that's when there had to have a conflict resolution of the 2 values. But because if you're doing, an interview with a patient and they have a surgical scar on the forehead or whatever, it's pretty obvious, and the interviewer can't stay blinded. So this was our best case scenario to try to do a blinded outcome.
Can one of you actually comment on the decision to use the utility weighted MRS rather than just a plain MRS?
You're muted, Jonathan.
So sure, the decision to use utility weighted MRS gave us several advantages. It had been previously described with its utility weights, and so it's a patient-centered and clinician-centered adaptation of the MRS that provides these utility weights. The nice thing about the utility weighted MRS, unlike the standard MRS, comes in through in an analysis. It provides you a little bit more power because it changes the variable to a continuous variable. So your analysis is a little bit more powerful in that you're not losing things between categories as much. And that's the major differences from the analysis. We still collected the MRS and then used the utility weights of the MRS to do the analysis.
We also did the logistic regression for the ordinal MRS at all the time points. We'll show you the results of that.
Yeah, that was a planned secondary analysis.
Yeah, but the primary outcome measure was analyzed using the Bayesian methodology and the posterior probability of success. One of the things that it's hard for people to digest is what futility means in these studies. And it's a very statistical definition. So when we got to 175 patients and the statisticians did the projection based on the 90-day outcomes, they looked at all the scenarios and they saw that it was statistically unlikely that we would get to a positive trial if we kept enrolling both the basal ganglions and the lobars. Now it doesn't, so there was statistical futility. Now that doesn't mean that there's the procedure for basal ganglions is futile. As you will see when we share the results, we don't know. That's still an unanswered question. And I'm sure Chris has a lot of very, very positive cases in basal ganglia evacuations that do really well. We had the same. We just had to make a sort of an executive decision. When you have a limited sample size and limited time, you have to focus on the population that's going to give you the highest yield. And that's what that adaptation took place. Anything else we should talk about before we get into the results? We're at 37 minutes.
I think that's good. That's pretty thorough.
All right.
Chris, Cara, anything?
I just had one question, if you could, that I was wondering about as far as the inclusion and exclusion. Is patients in other trials that had to wait for stability of the ICH and going so fast that you didn't have to, or you didn't get that opportunity? How did that affect?
That's a great, I love that question.
I love that question too.
We saw that actually as a differentiating factor and a strength.
Mm-hmm.
So whenever we saw a spot sign, we actually use that as the target. We wanted to land right on top of the spot sign because we could control it, get hemostasis and stop it. So it was never a deterrent. It was actually an opportunity. We thought that we had the greatest possibility of changing the outcome of the patient in a spot sign.
Yeah, remember that part of our planning for early surgery was obviously we want to relieve the mechanical pressure. We wanted to interrupt the inflammatory cascade, but really a big one was early hemostasis and prevent clot expansion. And that was primary motivators for us.
Right, so I think we can start sharing with you our results. So when we looked at assessment of patients, we had 37 centers in the US that participated in the study. And every site had a neurosurgeon and a neurointensivist as co-site investigators for the study. And that was instrumental for the success of the trial in terms of the logistics. We assessed 11,600 patients for eligibility. Alex, you want to run through that assessment for the numbers real quick?
Sure. The majority of we sort of had we didn't clean any of the screening data. It's whatever the site submitted to us. The overwhelming majority of the screening data weren't our target population. Around 3,700 of those weren't spontaneous intraparenchymal hemorrhages. Some of them, another 2,700 or so, were the volumes were too large, and then age was another big exclusion criteria factor that screened them out. So of those that were screened, 300 were randomized, 150 to the medical management group and 150 to the surgical group or MIPS. And at 175 patients that we enriched. And so the final location count, there were 48 in the anterior basal ganglia group for the surgery and 102 for lobar and surgery, 44 basal ganglia in the medical management and 106 in the lobar for medical management. There were 3 lost to follow-ups in the surgical group and 11 lost to follow-ups or withdrawals of consent in the medical management group. So our observed MRS at 6 months was 147 in the surgical group and 139 in the medical group. So we had a pretty good retention rate overall, and certainly maintained above our threshold for loss to follow-up. So,
Any questions? I mean, you provide for context the number of patients that were screened for MISTY?
I don't remember off the top of my head, but I think it was in the 14,000 range.
It was almost 15,000. So this is a lot less patients. I mean, MISTY had more patients. It was 500, right?
Yeah, 500.
So when you look through those, it's fairly comparable based on the sample size that we had of the patient selection. And it's a frequent question that we got in the presentation of ESOG was all the patients that were excluded and what those reasons are. So I think Alex ran through those really well. I think next we can talk about our primary outcome measure result. And
I guess we can add that, basically for all of our baseline characteristics, there really wasn't any difference between groups. It was all well balanced. And so there's nothing substantial. Our median age for both groups was around 64 years old, and so that other than that, everything was well balanced.
Yeah, when we look at the primary outcome measure, which is the difference in utility-weighted modified ranking scores, the difference between the surgical group and the medical group was 0.084, and that was significant with a posterior probability of superiority of 0.98 or 98% probability. So that was a very overwhelming positive result for the entire study population. When we looked at the 2 locations, the basal ganglia had a neutral effect, was at negative 0.013, with patients almost right down the middle in between the right and left side of the treatment effect. But the lobar location had a difference of 0.127 with a posterior probability of superiority of 0.996 or 99.7% probability of benefit of the intervention. So the results were strongly driven by the lobar location, and that was the primary result. So that was the most significant and what we were most excited about. When we look at the distribution of those across the different MRS categories, we saw those results represented, of course, in more patients in the MRS categories of 0, 1, and 2 in the surgical group, and more patients with the 5 and 6 outcomes in the medical management group as well. We looked at the results of the MRS at all the other time points, including day 7 or discharge, day 30, day 90, and day 180. And we did ordinal logistic regression for all of those time points. And across all of those, surgical treatment was statistically superior to medical management.
Can I ask you there, was that only in the
Yeah.
lobar groups across those, or was that in
This includes both
all surgical?
locations.
Both cohorts.
And that's
Yeah, any data we talk about is going to include both cohorts, unless we specifically say it. Yeah, Chris, good question.
And that's a good point. I mean, the adaptive design and the analysis, you do the Bayesian analysis is the overall population, which is really to control the false positive rates or type 1 error. So you have to maintain your primary analysis plan, which is all comers in the trial. And so all of our ordinal logistic regression was also, as they just said, that way. But it goes to the questions of, well, what shifts that that the overall effect is primarily seen from lobar, which is expected if you think about the design of the trial. When you stop one, what you really have is about 50% that are beneficial and 50% that are harm in the basal ganglia group. So it's somewhere right in the middle. So it stopped it at a reasonable spot and resource allocated to the lobar group. And so, if you think about the where they all sit and sort of treatment benefit, that, sort of intuitively makes sense of the observed data.
And then when you articulate the conclusion, do you have to stipulate that the conclusion applies only to lobar hemorrhages, or do you still state in the conclusion, this applies to surgically treated hemorrhages? How do we understand that after the fact, when we've got the data and we're thinking, are we applying this to surgical treatment of basal ganglia and lobar, or are we just applying it to lobar in the end?
I think, and I'll let both Jonathan
The
comment.
conclusion is,
Sorry.
I don't know.
You're breaking up there. You're breaking up.
It sounded like we were losing or breaking up. Yeah. So the conclusion is for both populations. The study was positive overall for the surgical group, but we do put a comment at the end that the results appear to be driven by the strongly positive effects seen in the lobar location.
Yeah, when you break. Go ahead, Gustavo. I'm sorry.
No, I was going to say, and for the basal ganglia, all we say is that it remains an unanswered question.
Right. Yeah, it's the posterior probability of success for the basal ganglia group is right at about 50%, 48% or something like that, which means it's the flip of a coin still, right? That we don't know. And so I think that the way to interpret it is exactly what Gustavo just described, and how we're describing it in the paper and how we're describing it when we talk about it, is that the whole trial is positive, but it's important to understand that that's driven by these lobar groups, which we then also selected because we were seeing that was going to lead, because they were meeting the predefined criteria for stopping, so that we had the most likely successful trial.
Yeah, it seems like you guys did a very good job planning the trial in a way, because you're coming into a space where so many trials had been negative. Misty was ongoing and had a certain strategy. So it seems like along all the decision-making points about how to design the trial, you designed it in the right way to maximize the chance of getting an answer that we could build on in the ICH community. And then in the end, that all worked out. So really commend you on the design.
Thank you. Yeah, no, I think we had seen the situation that evolved from Stitch, where lobar gave so many good hints on Stitch 1, and they were very close in Stitch 2. They were, some design, I wouldn't say flaws, but just characteristics that maybe prevented them from reaching the statistical significance that was needed. But they were close, and we were very aware of that. That's why we thought parceling out the locations and analyzing them separately was gonna be important to to the success of the overall study.
Yeah.
We can talk about the secondary endpoints that we're not going to tell you all of them because we need to reserve some for the primary manuscript results. There's some that we've presented in the past. Jonathan, you want to go over? I guess you get to pick.
Yeah, I'll highlight what we presented at ESOC. One of the things that we were most interested in looking at, and the mechanism through which we hypothesize that surgical evacuation is effective, is, as we've described, it's releasing mechanical pressure, interrupting an inflammatory cascade, et cetera. And so we were very concerned about the end of treatment volume. And so in our treatment group, the median into treatment volume was 14 cc's. And we had a change in ICH volume of about 44 cc's. And so that resulted in a percentile reduction of about 87%, 88% of all of the ICH. So very, I think that we can say, we feel as though that the surgery was very effective at removing the volume of the hemorrhage. And that seems to be associated with the final outcome as well, that the greater the extent of hemorrhage removal, the better those patients seem to do, which I think is at this point not surprising, but perhaps a bit of a relief to see, because it adds biologic plausibility to surgical evacuation and further pursuit of it as we move forward in with the lobar and the thalamic hemorrhages as well. We also saw a significant reduction in mortality. The mortality in the medical management group was very similar to what we'd seen in the MISTI group in their placebo arm at about 18%, whereas in the surgically treated group it was a 9%.
And that's at 30 days.
That's at 30 days. I'm sorry. Yeah, thank you, Alex. Yeah, that's a 30-day mortality. In addition to that, though, we also saw reduction in the mean ventilator days. The surgical group was only at about 5 days, whereas the medical management group was about 9 days of ventilator usage. And then an associated decrease in overall hospital length of stay and ICU length of stay. So all of these kind of pointed to the patients were getting better quicker, even early in their course in the surgical group.
I wonder, I don't know if you actually looked at this, but did you find significant variability in the amount of evacuation amongst different proceduralists? Or did you feel like, I think with all sort of procedural studies, we sort of wonder if the experience of the proceduralist sort of impacts your outcomes.
Sure.
And especially I think for something that is not a very common procedure to be done, I sort of wonder what it looked like amongst the different centers.
Yeah, that's a great question. So when we looked at performance, we only had, Alex, correct me if I'm wrong, but I think it's 7 outliers in terms of the volume evacuation. And those were pretty diluted in terms of the sites. There was not one site that had more than the others. There were isolated events, and across the different centers, there were different numbers of surgeons that were part of the study. Some centers had 1, some centers had 3 or 4. So we had a large number of surgeons that were participating in the study. And I think overall, the execution of the surgical protocol was very well done. We were recording all of the procedures. For quality, we reviewed the first 2 that were done to make sure that they adhere to the surgical protocol. And then we did ad hoc reviews of the videos. If there was a concern of a volume at the end of the procedure not being good enough, we would go back and see if there were technical issues, if it looked like it was difficult to get hemostasis. And we also had the feedback from the surgeons about the procedure, what they use for hemostasis, how was the blood pressure during the procedure, was this a case that was anticoagulation was reversed. We looked at the surgical performance in the context of all of those features to be able to see that. And then another important thing is that we had people with different levels of experience, and we also had community hospitals within the 37 sites. Not all were academic centers. And we saw good performance across all of those sites.
Did you see any features that predicted maybe worse evacuation percentage, like presence of a spot sign? You're targeting the spot sign, you're coagulating it, but maybe that makes it a little harder to do the procedure and get everything out, or maybe you encounter bleeding a little more often, or maybe early evacuation, or deep versus low bar, maybe deeper. It's harder to really see the whole cavity when you're in there with the end port. Did you see anything like that?
Not yet. We haven't finalized looking at all of the surgical factors. That's I think it's study number 4 in our list of things. But for what we looked at preliminarily, spot sign was not a problem. It was actually very favorable clot evacuations with spot signs. In the overall study, I think we had, what was our bleeding rate, Alex?
3%. It was
Yes.
3% for the surgical group, so it was very low.
Yeah, so 3% with included spot signs. I think it's a very nice number to see, and speaks to the ease of hemostasis. And this is a moving target, moving towards the side of being better and better. You know, I think when we started doing this, and Chris for endoscopic techniques as well, hemostasis devices and adjuvants weren't as good. Things keep getting better. Coagulation systems, bipolar cautery devices for the different methodologies keep getting better year after year. So I only expect that number to keep getting better.
I think that's a really nice thing about this technique is you can apply it to a broad set of ICH patients. You don't have to have stability. You don't have to exclude spot sign patients. And then when you treat those patients who are particularly high risk, you're still able to handle it in the case. And you guys have shown that. So that's, I think, definitely one of the things that maybe unlocked a positive result here is being able to take patients earlier, being able to handle challenging cases.
Can someone comment on the parafascicular approach, the surgical approach? Just I'm not as familiar with that, and I don't know how much we think that might factor in to the improved outcomes.
Yeah, that's a great question. So that has a lot to do with the postmortem of stitch. So when we looked at how the surgical protocol was defined in stitch, there was a lot of variability. There were some centers that did very big operations, including a hemicraniectomy and a partial frontal temporal lobectomy, and as aggressive a clot evacuation as they could get. And there were other centers that did a small craniotomy, so bone flap went back on, and they did a small incision in the cortex, a corticectomy, and did a conservative clot evacuation. And when we look at several of the studies that Dr. Mendelo has published subsequently, there was not a surgical awareness at the time those studies were designed on the impact of disconnection syndromes when you're doing this type of outcome measures, like a modified Rankin scale or Glasgow outcome scores and many of these other outcome measures. Those disconnection syndromes that we create surgically when we do a lobectomy come to bear, and patients don't perform as well. And when we started using this minimal access ports, one of the important principles in their design was to pick a trajectory to the lesion that may not necessarily be the shortest distance to the hematoma, but it goes along the long axis of the fiber tracts that are in the vicinity of where the hematoma is happening, so that you transect the least amount of white matter fibers and you try to decrease these disconnection syndromes as much as possible. For certain regions, that is less critical, but if you're talking about causing a supraparietal lobe syndrome or disconnecting the uncinate fasciculus at the frontabasal region, the impacts of those disconnection syndromes can be pretty profound. So that was the concept behind these parafascicular approaches, is taking the trajectory that is most respectful to the white matter, although it may not be the quickest, shortest way to get to the pathology.
And Gustavo, do you want to talk a little bit about the MRI studies that you did and that we did before the trial, looking at this trajectories?
Yeah, so when we did MIPS and several of the studies for tumor resection using the same devices, all of those required diffusion tensor imaging. We had tractography for all of those. And we used it to plan the trajectory, and we also used it to assess the footprint of those devices after surgery. And the trajectory that we came up with over and over again for certain locations were pretty standard. So for the basal ganglia, that trajectory was pretty universal. It was a trajectory that split two regions, the singular fasciculus and the superior longitudinal fasciculus, and it provided a longitudinal axis along the vector of orientation of those two fascicles. So the MR data was very good for that. For some of the lower locations, we were able to avoid disrupting the arcuate fasciculus or the ascending rami of the superior longitudinal fasciculus, and avoid those superior parietal lobule disconnection syndromes. We were very respectful of arcuate fasciculus fibers, so the amount of speech deficits was decreased in those trajectories. And then for the access to the posterior thalamus and the posterior part of the lateral ventricles, we were able to be respectful of the optic radiations, and the connections of the SLF and the arcuate to the back of the ventricle as well. So those MR studies were instrumental in building this, what we call now common corridors of access. And we, in certain pathologies like tumors, we still get tractography for those. In certain locations like thalamic hemorrhages, we still like to get tractography to plan. And in critical lobar hemorrhages adjacent to corticospinal tract, for example, we still get some tractography to be able to plan a very respectful approach if the hemorrhage doesn't come to the surface.
Got another question for the Emory team. You were talking about how at the beginning of the trial, some centers were having a hard time arguing that this was a emergent or maybe even urgent type of case. And so now that we have the results here, do we have an answer to whether or not this is an emergent case or an urgent case? Maybe that comes down to the differential effect of time that you'll see in your subgroup analyses. But do we treat this like an ischemic stroke and get that patient in there immediately? Or do we go to the next available room, even if it's the next day at hour 22? So what do you guys think about that?
So we can't show everything today. We have 12 and 8-hour data that's going to be included in the primary manuscript that will be published. But the biggest question in our mind was safety, because of course, clinical status also bears heavily in the decision to intervene immediately on the patient. And if you have a patient that is clinically stable and there are some logistical issues to get the patient to the operating room immediately, we still saw a benefit and good results within that 24-hour enrollment window. We didn't get as many patients as we wanted in what we would define as the ultra early group, meaning within 8 hours as we wanted to. And I think that is a group that needs further study. All we can comment on in regards of time is that it was safe. There were some concerns from older studies and maybe other techniques in the past about rebleeding with ultra early intervention. I think that we can definitely pass the page on that and say that with all the available techniques nowadays, ultra early intervention is safe.
Yeah.
And that's so important to know. I mean, you were able to enroll patients so much faster than Misty, and hopefully with the knowledge that you've now brought to the table, the next trial again, we'll be able to get more of those ultra early patients that you're talking about with the comfort of knowing that this procedure is safe.
Cara, I was going to have you comment a little bit. I think Gustavo and Jonathan both brought up really good points about how both the timing of evacuation and also the short time period in which the patient actually has active evacuation ongoing. How do you see that sort of changing the workflow in the neuro ICU and our resource utilization for the average ICH patient?
Yeah, I think thanks. That's a good question. I think this is very exciting, first of all, to see this kind of result for ICH patients, and knowing, as I've always suspected, that the faster we get them to the OR, that the better that outcomes are going to be. So I think that it's going to be really the onus is going to be on those stroke residents in the ED with that code stroke, seeing the patients and acting extremely quickly, just like we do for ischemic stroke patients, and acting as fast as we can to activate the surgery teams, get surgery involved right away, and really understanding that the time matters here, and not just walking away from the ICH, but staying on top of the patient and getting them where they need to go. It'll be interesting to see how this, it's nice that community hospitals were doing as well in this trial, but in the real world, how that's going to happen. And are we going to be having a lot more transfers now? Are there going to be ICH hubs where we have specialists who are going to be doing these procedures? And so it'll be interesting to see how that plays out in the real world. And I think, sorry, was that the last part of your question?
I don't really remember. Resource utilization, workflow.
Yeah. And so obviously the care for these patients is hopefully in the ICU going to be less really, having them stay in the ICU less, having less vent days, having less complications that are going to arise, and seeing that hopefully that's going to translate to less costs, less financial burden on the families of these patients. And so hopefully we can get this treatment for all patients, whether that be in a transfer system or just having these patients out in the community and having the surgeons out in the community be experts at this procedure. I also just want to say, I think this was a great use of the patient-reported outcomes. I think that's going to really change the way we do trials, hopefully. I think that we know a modified Rankin scale is maybe not the best scale. And so really thinking of how we can give the patients a voice in this trial, in all trials and in all of our outcomes, and understanding that what really matters is how the patient feels after the procedure, and how, if maybe their family feels, and the burden on the families that are taking care of these patients, and looking at outcomes that really matter to the patient and their families, I think is a really important way to really start from the get-go and designing trials that are using those kinds of outcomes. So thank you so much for using this user-weighted MRS scale and bringing this to hopefully more trials in the future.
This was amazing, and it's really incredible work, and I think like it is underestimated how much you guys are changing the field. So thank you very much for taking the time.
Great to meet you guys, and hopefully we'll see each other at NCS, and Chris, I hope to see you in Witch pretty soon.
Yeah, I'll see you there.
And when you guys do your next study on basal ganglia and then another study on thalamus, I'll invite you back for more Hot Topics podcasts.
I was hoping Chris was going to take that.
All right.
Thanks,
Thank you
everyone.
everyone so much.
Thanks, Alex, for setting
Thanks,
this up.
everybody.
Bye.
Everybody.
Thanks.